centered at the level of postgraduates, not surgical experience, but physics, optics, and all those things.
Okay, great.
So we are live.
We are live. So good evening, friends, and welcome to this 75th episode of our AIOS ARC initiative, that is an all India online postgraduate teaching program. This postgraduate teaching program, we boast of being different from other postgraduate teaching programs because here we cover the uncovered aspects of other teaching programs like OSCE materials or the questions which are not available to us at a single go in a textbook at a single place. So this was a question that types of intraocular lenses for one of the MS and DNB final exams. So we decided to have this particular theme for you to be able to write an LAQ on this particular topic. So who is better than Dr. Varun Malhotra, who is a senior consultant and clinical head for Center of Sight for AP and Telangana. He's a avid anterior segment surgeon and a prolific IOL master, I should say. Not master means a person IOL master. Okay. Thank you, Varun, for agreeing to be with us and sparing your valuable evening with us for this particular postgraduate teaching program. We also have senior discussants like Dr. Gopal Arora, a dear friend of mine from Nagpur, who is a director of ABIO Institute at Nagpur. He's himself a well-known phacosurgeon who has been doing live surgeries at various forums across the country. Another dear friend of mine who happens to be a postgraduate along with me during my postgraduation at Government Medical College, that is Dr. Praveen Verabari, who is a prolific phacosurgeon at Amravati, and he is currently the director of Evare Netralaya Amravati. So without much ado, let me request Dr. Varun to start his proceedings so that we can proceed. And really thankful, Gopal and Praveen, for this valuable evening, hours of your practice to be with us. Thank you.
Thank you.
Varun.
For inviting us. Thank you so very much.
Thank you, sir. Thank you, Dr. Prashant, for inviting me and giving me this opportunity also to connect with Dr. Gopal and Dr. Praveen. And of course, I've known Prashant sir for almost a decade now. He's my senior from Shankar Netralaya, much senior to me actually, but we do have a common umbilical cord which we can't, cut. And so I'll just start off with my presentation. And I think this is again half screen.
Yeah. Now go to the presentation mode.
Yeah. Yeah. So my topic for today is, and I'm clearly audible?
Yes, adequately well.
Thank you very much, sir. So my topic for today is types of intraocular lenses. And as Dr. Prashant mentioned, this is a very important question asked in the postgraduate examinations. And I would like to, do complete justice and able to give you insights into how you should be answering it. I would be talking more about theoretical aspects and how you should be answering this question rather than clinical pointers as to how to choose an IOL for a patient or how to counsel them. That will come later once you enter into clinical practice. So what is an IOL? IOL stands for intraocular lens. And this is an artificial lens which replaces the crystalline lens of the eye. It corrects the optical power of the eye once the human lens becomes cataractous due to aging or due to any other secondary causes. Now this lens, when it develops cataract, it has to be removed and replaced with an IOL. Sometimes the human lens can also be removed and replaced with an IOL purely for refractive reasons if patients have very high myopic power. There are two parts of an IOL. One is an optic. Optic is the central part of the IOL which focuses light on the retina. And then you have two side haptics. These are small filaments which are connected to the central optic. And this holds the lens in place in the eye. History of the intraocular lens. The first IOL was basically implanted by Sir Harold Ridley at St. Thomas Hospital on November the 29th, 1949. It was purely a case of serendipity wherein certain Air Force pilots who were riding the plane basically broke their screen, which was made up of PMMA. These PMMA particles went inside the eye absorbed the human lens, and few particles were left inside, and these pilots said that they were able to see better. That's when this idea came to Sir Harold Ridley that probably any lens made up of PMMA can be implanted so as to improve the vision of the patients who have developed cataract. So the first lens which was developed was a PMMA lens. It was implanted in a 45-year-old female. An extracapsular extraction was done, and this was implanted in the posterior chamber. And since then, the intraocular lenses have evolved over the last 70 years. The first generation IOLs were till 54 and were a copy of the original Ridley PC IOL. Second generation IOLs were basically very basic anterior chamber IOLs, which were used till 62. Then we had third generation IOLs, which were supported by the iris. The advantage was that they had less corneal decompensation as compared to AC IOLs, since they were placed a little deeper. But the disadvantage was that it caused pupillary distortions and iris chaffing. Then came the fourth generation IOLs or intermediate AC IOLs. They were more stable, better in design. But then anterior chamber is not the physiological site for an IOL to be implanted. And hence the ophthalmologists were in search always for something better, which could reduce the pupillary distortions, the chances of corneal decompensation, and give a more physiological a milieu to the vision. Fifth generation IOLs were made up of PMMA and were posterior chamber IOLs. And then came the modern PC IOLs and modern AC IOLs, which were made of better materials. And now, of course, we have seventh generation lenses, premium lenses like multifocals. We have torics, you have aspheric IOLs, accommodative IOLs, and all these different kind of lenses which you have to choose from. The advantage of a posterior chamber IOL over the anterior chamber IOLs or the iris claw lenses were that they sit in the proper anatomical site, which is the capsular bag. So you remove the cataract from the capsular bag and implant these lenses inside the bag, which is how it should be, physiologically be. They do not cause too much of a magnification. As you know, with aphakic glasses, there's a 20 to 30% magnification of the image, which is also the case with contact lenses in an aphakic patient. There is low incidence of lens decentration if there has been no posterior capsular rupture and if the bag is nicely supported. There is no zonular dehiscence. These lenses nicely sit inside the bag. And thereby, if you have done a good capsular polishing, the chances of PCO is quite less. The downsides can be with the new premium lenses. With the multifocal lenses, you see glare, you see halos, and sometimes photopsia as well. In smaller rexes, you can have anterior capsular phimosis or a capsular contraction, which can lead to a slight decentration of lenses. And obviously, you need glasses for near when you implant monofocal IOL lenses. The various materials used for IOLs, now non-foldable rigid IOLs were made of PMMA, polymethyl methacrylate. Nowadays, the bulk of the surgery is done with the help of foldable lenses. These are made up of silicone, hydrogel, and acrylic. Acrylic can be hydrophobic lenses or hydrophilic lenses. Collamer is the material which we generally use to make ICLs, which are phakic lenses inside the eye. And the haptic can be made of any of these materials, including polypropylene. Now, Collamer is a patented copolymer of hydrophilic acrylic and porcine collagen. Now, it is mainly used to make the posterior chamber phakic IOLs or the ICLs as we call them commercially. The intraocular lens design can be a single-piece lens or a three-piece lens. I will obviously be describing the differences in my presentation as we go along. The IOLs can have a plate haptic or can have an open loop haptics. Now, these open loop haptics can be C loop or a J loop, angulated or a planar haptics, and the lenses can be differentiated on the basis of their edge design and optic designs also. Now, this is how a single piece IOL looks like. It has less rigid haptics compared to a PMMA lens, but it is one piece, frankly, as you can see here in the picture. There's a uniform contact holding it in place, and this reduces the wrinkling of the posterior capsule once you implant it. Now, three-piece IOLs are basically, as you can see here, made up of one optic and two fragile haptics around it. So basically, the lens is not a single piece, but is made by three pieces. Now, these can be implanted either in the capsular bag or in the ciliary sulcus as well, in the event that the posterior capsule ruptures and the support is not adequate. Please always remember that a single piece lens should never be placed in the ciliary sulcus, because the haptics in these cases are slightly thicker and they can cause uveitis because of persistent inflammation. Now, these haptics will keep on rubbing the iris, and there may cause persistent inflammation leading to a persistent macular edema which may never resolve. Can also lead, this persistent inflammation can lead to increase in intraocular pressure and sometimes even bleeding through the iris vasculature. So this is something we call as UGH syndrome. If you implant it in the sulcus and get away with it, then probably you are quite lucky, but technically you should not be doing it. Now, these are the various haptic designs. You can have a C loop IOL, you can have a J loop or a modified J loop, and then you can have a single piece thickness. Haptic angulations, you can have angulated lens wherein the haptics are slightly curved forward. You can have a planar design as well. You can have a plate IOL and a modified plate loop kind of an IOL as well. And as you can see below, angle supported AC IOLs, iris fixated lenses, and then the sulcus IOLs, which are used for scleral fixated IOLs. Now, haptic angulation relative to the plane of optic. As you can see in the picture here, in the photo C, you have an angulated IOL, wherein in the PC IOL, there is an anterior angulation. The haptics are slightly lifted to keep the optic part away from the pupil. It helps in adhesion of the optic to the posterior capsule. It sits beautifully and also helps in pupillary clearance. AC IOL, posteriorly angulated lens to vault the IOL away from the pupil. And this is a classical optic design known as opti-edge design, which is nowadays used. The rounded anterior edge, as you can see here, scatters the light, which reduces internal reflections. Then in between, you have a sloping edge, which minimizes potential for edge glare. And then you have a square posterior edge, which facilitates a 360-degree capsular contact. So this is generally the optic design or the edge design. Now, an important concept to understand here is that, is the human eye perfect? The cornea basically of a young eye, the cornea has positive spherical aberrations. The human lens, which is placed behind the cornea, has negative spherical aberrations. And both of these, the cornea's positive aberrations and the negative aberrations of the lens, basically compensate each other to give us a good visually optical system, which is the human eye. Now, it's important to understand why we had to derive or basically invent aspheric design of the lenses. For that, we need to know what is a spherical aberration. Now, there are two important aberrations. One is a chromatic aberration pertaining to color vision, and spherical aberrations maintaining to your normal vision. Now, a spherical aberration is a phenomenon where the outer part of any lens does not bring the light rays into the same focus as the central part. As you can see in the picture below, the light rays which are passing through the outer rim of the lens are being brought to a focus at one point, and the rays which are passing through the central part of the lens are brought to a focus at another point. And this is where it causes a spherical aberration in the image. As you can see here again, just to summarize, the cornea has a positive spherical aberration, lens behind the human lens has a negative spherical aberration, and aging, as the lens keeps on becoming cataractous, aging increases the positive aberrations and hence increases the aberrations in the image, which is formed by a cataractous lens. And once you remove this cataractous lens, the intraocular lens which you want to implant in the capsular bag should almost try to maintain the same kind of asphericity so as to make a sharp image at the retina. And then you have these types of premium IOLs like a multifocal lens. We had something like an accommodative lens, which did not become very popular. And then you have toric lenses to correct the astigmatism. Toric lenses can be monofocal or it can be multifocal. Now, when you implant a monofocal lens in a patient's eye, obviously they can drive very nicely without glasses. They can, nowadays with enhanced monofocals, which gives good intermediate vision, people can actually do all their work on the digital devices, sometimes without glasses. But what about reading? They do need reading glasses. So how do we create multifocality in the eye with an intraocular lens so that a patient does not need glasses at all? Which is basically you have to restore the power of accommodation, because a normal human eye with a normal human lens has the power of accommodation, which helps us to do our distance work, near work, intermediate work, because the lens keeps on accommodating by the function of the ciliary bodies. Now, once the normal human lens is out because of a cataract, how do you restore accommodation? So we can do this either with the monovision concept, wherein one eye is dominant for distance, the other eye is more powerful and stronger for near. You can do it with the multifocal IOLs or with the help of accommodative IOLs. I would not go into the monovision concept because I am basically taking my lecture on the types of intraocular lenses. So I would now be discussing multifocal IOLs and how they help in restoring the multifocality of the eye. Now, basically, IOLs separate the light which is coming inside the eye or the optical system into two or more focus. And this results in multiple retinal images which coexist and superimpose with each other. Now, at one given point, only one of the images is basically sharp. So either the image for distance, intermediate or near, depending on where you are focusing, is sharp. This is only selected for visualization, and this is a concept of simultaneous vision, where the brain understands which vision is to be selected out of the three and to be focused. Now, any mammal, the visual system is not multifocal, and therefore the implantation of any multifocal IOL has to initiate a process of neuroadaptation. And this neuroadaptation can take a few weeks to sometimes 2 to 3 months for the patient to completely adjust to this new implant and the new way of functioning. And thereby the quality of image keeps on becoming better as the implant starts to function. However, when light enters the eye and the multifocal IOL splits or separates this incoming light into forming multiple images, it leads to a loss of contrast of these images. However, despite these limitations, multifocal IOLs still remains one of the best technologies to provide spectacle independence. Now, multifocal IOL was a concept which was defined by Hoffer and implanted for the first time by Pierce in 1986. And you can basically define multifocal IOL as an IOL with two or more focal points. Now, it can be classified as a refractive multifocal IOL, a diffractive multifocal, or an apodized diffractive, depending on the optical design. Depending on the focality, it can be bifocal if it has two focal points for distance and near. You have trifocal IOLs, which have three focal points for an intermediate vision also. And nowadays, the extended depth of focus EDOF IOLs, which have more than three focal points, which gives an elongated focus of vision over a range, basically. So it's no longer about distance, near, and intermediate. It's a continuous range of vision. Now, to understand what are refractive multifocals and what are diffractive multifocals, we need to understand refraction and diffraction. So diffraction is as you can see in the picture here, is the bending of light around an obstacle or through an opening. So the light bends. And refraction is the bending of light once it moves from one medium to another. So refraction is bending from one medium to another. Diffraction is bending around an obstacle or an opening. Now, refractive multifocal IOLs have an anterior surface which have rings or a sector-shaped optical zones with different dioptric powers. And these different dioptric power zones provide various focal points, which helps the eye to form images at different focal points. And this helps in distance, intermediate, and near vision. However, they are dependent on the size of the pupil to utilize the zone of the lens. Limitation is very high dysphotopic symptoms, high intolerance to pupil decentration because they are dependent on the size of the pupil, and there's a significant loss of contrast sensitivity. And this is how a typical refractive multifocal IOL would have. It would have approximately 4 to 5 zones. The innermost is the major dominant zone for distance. Then you have a large near dominant zone. Then you have a distance dominant zone, and then a near zone again. So it's alternate zones of distance and near, wherein the dominance lies in the center, and the outer two zones are basically supportive zones. A diffractive multifocal IOL is different from a refractive multifocal IOL in its principle. It utilizes diffraction in conjunction with refraction to create a new foci. As you can see here, the refraction is done by the anterior surface and diffraction is done by the posterior surface, which has multiple grooves and microscopic steps. Hence, the light is divided into two foci, 41% for each focus, and 18% is lost to higher order aberration, which is why there is a loss of contrast in cases of diffractive multifocal IOLs. But the major advantage is they are less pupil dependent and there is little more tolerance to decentration. However, that is not what is an ideal way, but there may be a little bit more tolerance to it. Now, what is apodization? Apodization is basically steps, or the height and the steps which are created in the posterior zone of the lens so that the amount of light distribution is more equal. And as you can see here, gradual reduction in the diffractive steps from the center to the periphery helps in the is basically called as apodization. And as you can see here, you can have bifocal diffractive lenses, you can have trifocal diffractive lenses, and trifocal non-apodized diffractive lenses. So in non-apodized lenses, the height of the steps does not reduce, it remains the same. But in apodized lens, multifocal lenses, the height from the center to the periphery keeps on decreasing. And this makes them less pupillary dependent and more tolerant to decentration. So refractive multifocal IOLs give excellent intermediate and distance vision, but diffractive multifocal IOLs give extremely good near vision with a fair intermediate vision. Refractive multifocal IOLs are pupillary dependent, diffractive are less pupillary dependent, and patients basically who read for prolonged periods may not be accepting refractive multifocal IOLs very well. Both with refractive and diffractive lenses, there is the loss of contrast sensitivity. There can be glare and halos because of the scattering of light, because of different zones. But with bilateral implantation, there is a summation effect wherein this glare and halo starts getting a little compromised, and because of the summation of the lens in the both eye. Especially in patients who have retinal pathologies, we must try to avoid implanting a multifocal lens because there is less satisfactory visualization of the fundus, and you also require neuroadaptation, which takes about 6 to 8 weeks, and hence it does take some time for exact visual clarity to come. Whenever you are trying to implant a multifocal lens, always warn the patient that they may have a little bit of glare, halos, and starbursts, and this is how these images look like. We also have extended depth of focus lenses nowadays to produce multifocality in the eye. There is an echolid design feature which basically helps to get an extended range of vision, and there is an achromatic technology which reduces chromatic aberration. And this is how the defocus curve of a trifocal IOL is. As you can see, it gives very good far vision, a fair amount of near vision with a decent intermediate vision as well. And this is how you define a near, intermediate, and distance vision. understand what are the different presbyopia correcting lenses available today. I have no financial interest, but these are the different brands of multifocal lenses which are available nowadays to an operating surgeon, which the postgraduates, if they know the name, will only enhance and add value. And these were a few studies which were done to compare the various lenses. And this was a study which was published, way back in 2018. And it said that although unilateral implantation of a multifocal IOL provides patients with good levels of spectacle freedom, but there is always a favor towards bilateral implantation because that does not compromise the contrast sensitivity too much because of a summation effect. And this was a subjective evaluation of uncorrected vision in patients undergoing cataract with multifocal versus monovision. And it said that though both techniques gave satisfactory results, but multifocals were slightly better. However, they should not be put in patients who are avid night drivers. And this was the visual performance after bilateral implantation of two presbyopia correcting intraocular lenses. One was a multifocal, other was an EDOF lens, and both these lenses seem to be good option for patients with intermediate vision requirements. However, trifocal IOLs give better near vision compared to an EDOF lens. So this was about monofocal lenses, and then a little bit about the multifocal lenses, their types, their designs basically, and also a comparison between monofocal, multifocal, and EDOF lenses in the various studies. Now it's important to understand how do we correct astigmatism. So most people are born with some degree of astigmatism, and a lot, patients who have astigmatism more than one diopter require astigmatic correction as well, because it can distort and blur the vision and the image which is being formed. And for this, toric IOLs were introduced. Toric lenses refer to astigmatism correcting lenses used at the time of cataract surgery. It was first introduced by Shimizu. Patient selection is important. IOL calculation of prime importance. Marking is extremely important because you need to place these toric lenses in a particular meridian, in a particular plane, so as to correct astigmatism. These are various ways in which it can be done with the help of a bubble marker or on a slit lamp. A freehand marking is a very crude way of doing it. Advantages: the toric lenses give better results than limbal relaxing incisions. Limbal relaxing incisions can be made with a guarded knife, nowadays with the femto platform like the Catalyst, but the outcomes are not as predictable as a toric lens. Average post-op toric IOL rotation has been found to be less than 5 degrees. If you are giving a good AC wash and washing all the visco, it is advised to go beneath the lens and give a good visco wash, which reduces the chances of an IOL rotation. Post-op residual astigmatism has been found to be less than 1 diopter in 89 and 88% of patients with multifocal and toric IOLs respectively. What may be the disadvantages? An improper alignment or a rotation of the lens after the surgery may result in more residual astigmatism. For every 1 degree of IOL rotation, 3.3% of the cylindrical power comes back. What that means is that if your IOL rotates by 10 degree, you may have 33% of the cylindrical power back. Irregular astigmatism cannot be corrected with a toric IOL, and that's very important to understand. So after toric lenses, we come on to the accommodative lenses. Now, the accommodative lenses were introduced with a lot of fanfare, but somehow did not find too much of following. So what is the whole concept behind an accommodative lens? Now, in pseudophakic eyes, basically ciliary muscles continue to remain normal and function. So as we know, in a normal human eye, it is the contraction of the ciliary muscles which leads to accommodation. Now, even when the cataract surgery has been done and a lens has been implanted in the capsular bag, the ciliary muscles are not paralyzed and they continue to remain functional. So the whole concept of designing accommodative IOLs was to use the ciliary muscle function going forward. So there are two different types: single optic IOLs and dual optic IOLs. Now, single optic IOLs was something like a crystal lens which was introduced in the Indian market. The concept behind using single optic accommodative lens is to implant them in a capsular bag. Now they have hinged plate haptics. We generally do post-op cycloplegia, give post-op cycloplegics in these patients so that the anterior and the posterior capsules stick to each other. They fibrose around the haptic so that it becomes one piece. And the optic is obviously in the bag, and the haptics get fibrosed in the capsular bag between the anterior and the posterior capsule. So as soon as there is a contraction of the ciliary muscles, as the ciliary muscles bulk up, there will be pressure in the vitreous cavity. This vitreous will come forward and it push the optic in the front, causing a temporary forward movement of the optic. So the accommodative lenses were using the principle of bulking up the ciliary muscles so that the vitreous is pushed forward. This forward pushing of the vitreous will push the optic forward, and this will cause the forward movement. A 1 millimeter shift of a thick optic can result in 0.8 diopters of accommodation. And in basically shorter eyes, this accommodation can go up to 1.8. Various studies found that in an average eye or on an average, we can expect 1.3 diopters of accommodation with 1 millimeter of a forward shift. So basically a approximately 2.5 millimeter of forward shift can lead to an accommodation of +3 diopters, which would be required for extremely clear and good near vision. But it was almost impossible to always predict whether these patients will eventually get that kind of a forward shift or not. So predictability was an issue. What were the dual optic IOLs doing? Now, these are open chamber IOLs which fill the capsular bag, but there is a fluid space in between. So there are dual optics and there is a fluid space in between. So you have a high positive biconvex anterior optic and a weaker negative concave, posterior optic, which is joined to each other by spring haptics. So they retain the natural dimensions of the capsular bag as far as the axial thickness of the lens is concerned. They were almost as thick as the normal human lens because of two lenses being implanted together. There was a 1 millimeter of separation between the two optics with the help of a fluid, and there was a fluid in between and obviously spring haptics. And this was able to produce an accommodation of 2 to 2.5 diopters. So what was the concept behind this, accommodative IOLs, dual optic accommodative lenses? So when the ciliary body is at rest, the zonules are put on stretch, producing axial shortening of the capsular bag. So when there was an axial shortening of the bag, the optics were pulled together. And when there is an accommodative effort, the zonular tension is released and the optics are separated, the spring haptics are released, which causes the accommodation of the lens, and hence the patient is able to have good near vision. I will summarize this concept once again. Whenever patient wants to accommodate, the ciliary zonules are released. As a result, the two optics separate from each other because of the release of the tension. And this separation of the optics tends to produce the accommodation effect. And this was the other design called as Accolens lumina, wherein there were two sinusoidal optical surfaces which slide across one another. So there was a very minimal space in between, and these two optics were sliding instead of pulling apart. And then there is a new concept of curvature change lenses, and not much is known about them. Probably the research is going about it by changing the curvature of the optics anterior and the posterior curvature of the intraocular lenses to try and bring some amount of accommodation. I'm not going into details because they are not very popular in clinical practice at present. The disadvantages of accommodative lenses is very small optics, so more amount of aberrations. The visual quality is not great. There can be a failure of accommodation also sometimes if the capsule and the fibrosis, basically the haptic and the capsular fibrosis leads to opacification. The whole principle goes basically awry if this happens. You cannot do a YAG capsulotomy if you form a PCU. You just have to live with it. You cannot do it. And of course, the cost was very high. So because of these reasons, less amount of predictability, cost factor, the accommodative IOLs did not become very popular and never took off. Now, after all this, we come on to the different types of lenses which can be used in abnormal situations. We have something like a scleral fixated lens, which the vitreoretinal surgeons use. Now, this is implanted when you have an absent capsule or a defective posterior capsule. They are available as foldable, non-foldable, single piece or three piece. And as you can see in the picture here, they have eyelets through which the suture can be passed for fixing these lenses onto the sclera. The suture used is either 9-0 or 10-0 Prolene, and they are placed through a ciliary sulcus. The complications of a scleral fixated lens is that they obviously, if they're very close to the corneal endothelium, they can cause corneal edema. Sometimes if some amount of vitreous gets enmeshed, it can cause vitreous persistent traction and lead to a retinal detachment. Always better to do a complete vitrectomy when you're implanting an SFIOL. Intraocular hemorrhages, and very important is suture erosion. Sometimes suture erosion can lead to tilted or decentered SFIOLs. Infection is obviously can be a complication in any cataract surgery with any kind of lens. Iris fixated lenses, which were introduced by Wurst in 1972. As you can see in picture A, the Singh and Wurst iris claw lens. This photo, if you can see, is almost seen in every textbook, and these lenses were popular at one point of time, popularized by Dr. Daljit Singh. And then you have these artisan iris claw lenses, wherein the basic principle is the same, wherein the two haptics are enmeshed in the iris, just that the design is slightly more rectangular. So iris claw lens can be placed above the pupil on anteriorly, or there can be a retropupillary fixation also. Now, as I had mentioned, the whole principle is that there are two opposed claw haptics. They fixate on the iris in the mid-peripheral iris, because mid-peripheral iris is less vascularized, it is less reactive and virtually immobile. So chances of the lens sitting beautifully is better. Chances of a bleed is much lesser. It allows the pupil an unrestricted ability to dilate and constrict because the mid-periphery is slightly less reactive. The indication for iris claw lenses can be again a large PCR where you cannot place the lens in the sulcus, can be a subluxated lens where the whole bag may come out, zonular dehiscence, or implantation after any other reason where the eye is aphakic. So after scleral fixated lens and an iris lens, you have an anterior chamber IOLs or AC IOLs. And this is the normal design of an AC IOL. As you can see here, you have to insert these haptics in the anterior chamber angle against the scleral spur. The sizing of an AC IOL is important. You first have to do the white to white diameter and add 1 millimeter to it so that it snugly fits into the angles. Indications same as an iris claw lens or an SFIOL, absent capsular support. But you must have a deep anterior chamber here to be able to place an AC IOL. Contraindications are any kind of a corneal dystrophy or iridocorneal angle damage or a lack of sufficient iris support. Once you place an AC IOL, sometimes it's very common to see a damage to the angle and the iris. This leads to chronic inflammation. Chronic inflammation can lead to persistent iritis, leading to high intraocular pressure. The UGH syndrome is common sometimes after an AC IOL implantation, corneal endothelial damage, and eventual decompensation, which may then warrant an AC IOL explantation with a endothelial transplant. We have something like aniridia IOLs. These comes in various designs. As you can see here, they have a colored diaphragm and then a clear optic in the center. And this is the general size of the lens. Piggyback IOLs is a concept wherein you put one lens over an existing IOL, and sometimes you implant two IOLs simultaneously. One IOL is in the capsular bag and the other IOL is placed over it, most of the times in the sulcus. Sometimes you may be able to implant it in the bag as well. The whole idea with some surgeons basically believe that it is easier to implant a second IOL to correct a residual spherical error than to explant the lens and replace it, because an existing lens may have formed a good amount of fibrosis with the surrounding tissues. Explanting this lens may cause more damage than advantage to the patient. The complications of a piggyback lens can be interlenticular opacification. Like you have a PCO, if you have epithelial cells which migrate between the two lenses, you can have a interpseudophacous L-Schnick pearls called as red rock syndrome. And in these cases, there is no other option, but you can sometimes try to use YAG, but you end up making pits in the lens, and eventually you may have to explant this lens. AMD lenses is basically, I was obviously searching the literature when I wanted to make this presentation for the postgraduates, and I came across something called as AMD lenses for macular degeneration. So as you can see here, in a healthy eye, the images are focused on the macula. Now, by putting these lenses, you basically change the operation, replaces the real lenses with two artificial lenses, one in front and one behind the iris. What it does is that it basically refracts or changes the course of or the direction of the rays which are entering inside the eye from the macula to another healthy part of the retina, and at least helps us to form some kind of an image, and this information is then sent to the obviously transferred through the optic nerve. And this is how the AMD lenses can be used. Of course, it is still in research, and still a lot of things need to be understood about them. But then these lenses have a central 1.5 millimeter diameter in the center with a +10 add. And this +10 add gives a 2 times magnification, which probably can help patients of ARMD. The other recent advances which I found over the literature is light adjustable IOLs being worked on, telescopic IOLs, and electronic IOLs. Now, I would like to just throw some light on the telescopic lenses. Now, this is how a telescopic lens would look like. This would have to be implanted in the posterior chamber. Now, the lens basically consists of different micro lenses put together which magnify objects. Now, these lenses, the indications for these kind of lenses would be patient with extremely low vision, people having ARMD or some kind of a heredomacular dystrophy. And obviously, these kind of lenses would not be indicated or implanted in patients with normal vision. In normal patients, we would still want to do a monofocal or a multifocal lens. These are in certain situations, So they are held in position by haptic loops, and this is how this lens would look like. And this is something called as electronic IOL. Again, I found this over, the search when I was searching and about the kind of research going on. And this is what I found, that this could be world's first implantable lens with artificial intelligence, some kind of research going on in Netherlands. The pupil responds to accommodation by getting smaller. So once the eye accommodates, there are sensors in this lens which would know that the eye is accommodating, and the pupil will respond to this accommodation by becoming smaller and help in near vision. Now, there is a change in the molecular configuration of the liquid crystals will happen over, there will be liquid crystals which will keep on changing their configuration at different focal lengths to alter the optical power. And there will be a cell inside these lenses which will have probably an expected life cycle of 50 years. Now, this is obviously very exciting to look at and to hear, but how much of this is really practical, time will only tell. So thank you very much. This is all what I had to describe on the intraocular lenses. And I would obviously, if you can mention about the recent researches and what is going on along with what we already know, this would only help you and give you more brownie points. Thank you very much. Thank you for patient listening.
Thank you, Dr. Varun sir. That was a wonderful presentation. If we can just stop the screen share, then we can have the discussing here. We have two eminent phaco surgeons here with us, Dr. Praveen Vyavahare and Dr. Gopal Arora sir. First, we would like to open the comments from both the discussants and then we'll go with the question and answers, please. First, we can go with Gopal, sir, please.
Yeah, thanks, Dr. Varun and Dr. Srinivas. It was classical book teaching, I would say, especially for the postgraduates, because you have covered the entire range of how the lenses were invented and what all positives they're offering to a patient. So basically, when it comes to why was the intraocular lens being invented, basically to replace the cataract, the natural lens which is being taken out, and to replace it with an artificial lens. So then came that what advantages can it offer apart from the monofocal vision? So the concept of removing the toricity by the toric IOLs, then came how would you can give a best near vision to the patient. So came the concept of the multifocal IOLs, then came the trifocal IOLs, but again it had the disadvantages of glare, halos, night vision, pupil dependency. So even the newer lenses like the extended depth of focus lenses which have come, and more so ever even the enhanced monofocal. And if you go by the definition of these EDOF, actually it has changed now. EDOF are basically if you give more than zero 0.5 diopter of depth of focus or zero 0.2 logMAR if you have to achieve. Even those enhanced monofocals falls in the category of actually EDOF lenses. So basically the concept of getting the near vision and removing the disadvantages of glare, halos, night vision, and pupillary dependency is what an ideal lens would look like. So I'm sure these EDOF lenses with few more modifications are going to take in future and are going to replace even the trifocals. That is what I feel.
Yeah, rightly said. Thank you. Thank you, Gopal, sir. Praveen, sir.
Yeah, it was a very nice talk, very elaborative. Actually, the PG should understand because of so many of intraocular lenses are available now. So they should understand that the lens like multifocal IOL, which can cause aberrations on the IOL surface, may not be suitable for every individual. So a customization in every patient is important in a cataract. In each and every patient who has a cataract, but a multifocal lens or a EDOF lenses, they have their limitation. If the patient has a retinal issues or a glaucoma or any other problems which they have a lesser contrast vision, then these lenses are not suitable for those. And if the patient is a night driver, then a multifocal or trifocal lens can cause a lot of aberrations or dysphotopsias or glare and halos. So the choice of lens has to be selected according to the patient. So there's so many lenses but for the toric lens for every patient who has a cylinder which is more than 0.75 diopter or 1 diopter, this lens can give you the excellent result. And regarding the Dr. Gopal was telling about the EDOF lenses, there are so many EDOF lenses are available nowadays. So each EDOF lens has a unique design, and you need to understand the design of the lens and the number of the aberrations which they cause, and then you have to select the patient accordingly. At the same time, the IOL power calculation is a very important thing if you are going to put these premium lenses, and the IOL master or other optical diameters are very important tool to decide about the IL power.
Thank you. Thank you, Praveen, sir. So we'll open up with few questions. As Praveen, sir, rightly mentioned about the choice of IOL when you have certain conditions like glaucoma or say for retinal conditions. So I open it to all three of you. So now coming to the question, what would be your choice of IOL if the patient is having milder forms of AMD? Of course, the multifocals or the EDOF, all these lenses becomes contraindicated when it has a macular scarring or a DME or all those things. But the patient is having very minimal AMD, just detected drusen's clinically. OCT shows very few drusenoid PEDs. What would be your choice of intraocular lenses in such situations?
So for me, if the patient is okay to wear the glasses, then definitely the monofocal IOL will be the lens of choice. But if patient wants to go for the slight, don't want to wear a glasses, then if the patient is say around 75 years of age and there are only few drusen, otherwise healthy macula, the vision is 6, 6, everything is okay, then we can go for the EDOF or multifocal lenses. But if the patient is a quite young patient, very large drusen, a yellow drusen, a soft drusen, those they have a very high chance of developing into the wet AMD. Then these are the patient we should avoid the more multifocal lenses. And for the EDOF lenses, we need to understand there is many, and it's a big range of EDOF lenses. The EDOF lenses which can give a intermediate addition of only 0.5 diopter like a Ihans lens, it gives a very good distance vision. But the newer generation EDOF lenses, there are few Indian lenses which have the EDOF, which gives a unaided N6 or N9 vision. And these patients may not have the glare and halos, but the blur effect which produces this lens produces can cause the and degrade the optical quality of vision. So this is definitely no if the patient has an advanced form of AMD. But like lenses like a Ihans lens, which gives us only intermediate vision or addition of around 0.5 diopter, we can go for these lenses in this milder form of AMD.
Gopal sir, your thoughts quickly. Sir, you're on mute.
See, age plays a very, very crucial role in taking a decision in putting any IOL in a especially case which you have mentioned for early AMD. If a age is around 40 years, and my only choice would be monofocal IOL, because 40 years getting into 50 60 years, it is going to increase. So that case, I would definitely put a clear-cut monofocal. If at the age is maybe 55 60 and is a minimal AMD, then the extended depth of focus lenses, especially the enhanced monofocal, what you call, I mean, they have absolutely no side effects of what you call as the trifocal or the multifocal lenses. So they can also comfortably be implanted.
Varun sir, I think you explained about it very nicely, but I just like to throw a point here. There was a wonderful article showed by Friedman et al. As to what is the age usually when the wet AMD progresses more, or the demographics of geographical atrophy. We see that usually more than 75 years of age. Until then, it is only 1 to 2% of conversion rate. But it's usually after 75 to 80 that it reaches around 7 to 8% of the chances. So the question remains here is why you want to divide people of the multifocal lenses at the age of 40 or 45 or even 50 if they have a very minimal macular changes, because most of these changes usually happens over the ages when they reach 70 or 80. So the 20 years they can still enjoy the vision is what the debate which keeps happening. I just don't want to go into that debate. But one thing I would like to tell that if, there is a very clear classification which is given by Andrew Grabowski on these things. He explains that which are the cases any patients without any clinical evidence of macular diseases. That means no signs of drusen or pigmentary changes. Definitely, they are the patients for any set of IOLs. Either it can be monofocal, multifocal, EDOF, or any set. But patients with early maculopathy, that means soft drusen or pigmentary changes with relative sparing of the Snellen's visual acuity, these are the patients who have loss of contrast sensitivity at lower spatial frequencies, but they are not a direct contraindication for any of these EDOF or multifocal lenses. But as Praveen sir and Gopal sir said, patients with severe AMD, presence of large drusens, geographical atrophy, or the patients have already gone in for the wet AMD or proliferative AMD, MNV cases, there is macular neovascularization, what we call. I think these are the cases where we prefer only monofocal lenses and no other choice of multifocal lenses at all. So it's a wonderful article. I request all the students here to go into that because he describes that most of these, what we think are all hypothetical, and they don't have any strong evidence-based medicine to prove that even in mild cases of AMD, that the multifocal lenses becomes a contraindication in those cases. So, Varun sir, your thoughts on this? Last on this topic, we can go to the next question.
Basically, Dr. Srinivas, what I do in my clinical practice is that if I find any form of a, even if it's an early AMD or frankly any form of a change in the macula or the retina, I definitely don't go for a multifocal for sure. I basically, if as you correct, I mean, if the patient is quite young, as Dr. Gopal was saying, maybe 45, 50 years, I would offer them an EDOF lens because they don't have the glares and the halos, which is associated with the trifocal. So, in an EDOF lens, by and large, the patient is able to still do 90 to 95% of his near work. We just counsel them that they may need a small reading glass, maybe a +1 sometimes for very small fine print, and they may accept it. So the loss of contrast is more in a trifocal or a multifocal lens vis-a-vis a EDOF lens. And these patients who have some kind of even if it's an early macular pathology, this with loss of contrast sensitivity, they may not be very happy. I mean, I do not wish to take that kind of a risk at all. So for me, even if the patient is 45, 50, I would definitely not put a multifocal lens. I may offer them an EDOF lens.
Very good. The next question is the patient having, you do a 78D examination, 98D examination, absolutely clear macula. You don't find any of the clinical findings. How many of the doctors here, the panelists here, prefer to do an OCT before the cataract surgery? Now, that's the very important topic. I just wanted to know from the panelists.
So I do an OCT for every cataract surgery. For every cataract surgery, an OCT
Dr. Gopal sir, you do OCT in all your cataract surgeries?
Not on very, I mean, patients who are really poor, I don't do, but any patients who I'm putting a average imported aspheric IOL, definitely I go for an OCT before I put even a routine monofocal, I would go for an OCT.
So why, sir? No imported IOL. Indian IOLs don't require OCTs, is it? Only imported the IOLs requires OCT.
I'm
Just joking.
talking in terms of financial aspects. If the patient is, I mean, affording enough, because even OCT, you won't be doing it free of cost. So it's for your academic interest. You can do every patient, but I'm just talking. I mean, practical tips are if the patient is going for at least a medium range of even a monofocal. Forget about multifocal. Multifocals we need to do every patient an OCT, but even in monofocals, if a patient is well off, then definitely I would go for an OCT even in monofocals.
Praveen sir.
In my setup, actually, OCT is very important tool. In every cataract patient, we do, it is included in a cataract profile. We do a IL master, OCT, and the eye trace examination. And even if you do
It is a part of your package, or you charge them extra?
we charge extra, sir. It's around 2,000 rupees for every patient. And there are definitely certain number of patients, irrespective of doing a very good 90D examination on the slit lamp. There are few patients, particularly they have those who have a slight vitreomacular traction, VMT. So that is very, very likely to miss, or maybe a slight lamellar macular hole or something, or macular thinning. These are the patients which cannot be detected by the slit lamp examination. So that definitely is a very important tool. And I have experience few years back in one of my patient. He was very unhappy after the cataract surgery, and OCT revealed that he was having a VMT, and he was very unhappy. It's almost 10 years back, and from that patient onwards, I am doing the OCT on each and every patient of the cataract.
I had a similar experience, Dr. Praveen, wherein I implanted a multifocal. The patient had 6/9 vision. He was not able to see the last line. I did an OCT later and found a very thin ERM. So after that, I started doing OCT for everybody, because sometimes very thin ERM you may miss. And it's better to explain the patient this pre-operatively, because he thought that I have created the ERM during the cataract surgery.
Okay. Sir, the last point which we want to discuss is about the secondary IOLs. The patient having a clear aphakia, young patient, say around 40, 45 years of age. What would be your choice for scleral fixated IOLs? He described various types of scleral fixated IOLs. I just want to know, so that we can take a few more questions. Quick answers from Dr. Praveen and Dr. Gopal, sir, please.
In my setup, I used to do a scleral fixated IOL few years back, but now my VR colleague has taken up, and he is putting that upper swami lenses with that T-type tuck, which is available, and it's very easy to implant. I don't remember. It's a T-flex or something.
CMT flex lenses.
CMT flex, yes. He is putting a
so
CMT.
that is your choice of
and it gives a very good result. Very nice.
Gopal sir?
Even with the oral lenses that I'm using, little fixated lens, with or without glue, even the tucking of this lenses, that works really well. Even I have seen in a few cases that iris claw lenses, even if there is not much of vitreous, you do a minimal vitrectomy, even those iris claw lenses works equally well.
The problem with the iris claw lenses, it doesn't give a very good fixation. There is a lot of movement of the lens, phacodonesis, and it can cause issues. And in my practice, when I used to do iris claw lenses, these are the patients who are coming now. There are two patients in last month only, in which the claw has it's
Dislocate. Yeah.
moving. The one of the
Yeah.
claw is disengaged from
Disengaged.
the iris. Yeah, disengaged.
Disengaged, and that actually becomes a very difficult point if only one haptic of the iris claw falls down, is because you have to try to cut and then try to remove it. There are chances that it might fall down because one side it is enclaved and the iris is stuck inside. And cutting that usually is a very challenging, but some doctors prefer to even do it nicely without damaging the iris much on the other side. So, any of your thoughts, Dr. Varun, on the sutured SFIOLs? So, where do they have the stand in the present day for the sutured SFIOLs?
Frankly, in I have a super specialty setup, so I again, as you know, like the other, like Dr. Praveen, I referred all the Vikia patients to to my retina colleague, and they what I've seen them is by and large they do a glued IOL now, or they do it with the Yamane technique, wherein they use the
Yeah.
cautery to create a there. I frankly, if I ask you, I have never seen them do a sutured IOL in the last 3 4 years.
Yeah, sutured IOL, I think because of the disintegration, there are issues, and we have stopped. Many of them have stopped doing it. But still, 4-point fixation of suture, especially with the Gore-Tex, that is really giving a promising result, better stability. Even in the sheen plug imaging, if you see, there is very less tilt in these kind of cases, and that is where the Canabrava technique, the Sergio Canabrava, who described the dumbbell on the both side using the 5-0 or the 6-0 vicryl and trying to flange it, or even the Yamane's technique. The Indians are known for jugaad. So Indians have bought up a lot of modification for Yamane. And if Yamane sees that, I think he's going to definitely see what India is capable of. So that kind of modifications we are seeing nowadays with a modification of Yamane technique. The last question to Gopal sir, where do we stand with the ACIOLs now? Because some surgeons says that ACIOL still has a role. A good fixated ACIOL definitely has a role to play, rather than some surgeon messing it up with the iris claw or trying to do a SFIOL when they are still not trained. Better fix an ACIOL. Where do we stand today with the ACIOLs?
Practically, if I put, I mean, I have to give my opinion. I don't see ACR, especially the technique that scleral fixation lenses have undergone, and it's such a fast technique. That's the reason I was telling you about that iris claw also. It's a very fast procedure, iris claw lenses. If at all you have to go for, apart from scleral fixation, iris claw would be my first choice, not the AC one.
Okay. Praveen sir, last comments from your side.
No ACIL for me. I have not used since many years. I don't think it stands in today's scenario.
Okay. Varun boss? No?
The same thing. I've not used ATI because frankly, with the new machines and the techniques, the chances of having, if IKEA in a patient has become anyways very less. We are able to put a three-piece lens. The very once in a year, whatever patient I have to refer to my retinal surgeon, they end up doing a glued IOL or as you said, the Indian modifications of the Mane technique. So we haven't seen ACIOs for a long time now, especially in this practice, in our practices. Maybe in a camp setup, it may still work, probably.
Yeah. Probably. Yeah. Great. So thank you, sir. Thank you very much. It is 9:03. I think we come to the conclusion of this webinar. Great talk by Dr. Varun. Thank you very much, Varun sir, Gopal sir, and Praveen sir. Very practical and very crisp messages you have given to all our postgraduates. We would love to have you again back in further meetings of ARC. So on behalf of our chairman ARC and all the team ARC members, I would like to thank all three of you, and most importantly, the support from admin They have been very kind to do that. And Sunil, Mr. Sunil, and definitely Zadio and the whole team of Numerotech, they are there. And the postgraduates who are here and who have listened to most of these lectures. Thank you very much. We'll be coming back again next week with few other interesting topics. Thank you once again. Good night.
Good
Thank you.
night. Good night.
Thank you.
Good
Good
night.